Good morning, everybody. I'm Dr. Francesco Giganti. I'm a consultant radiologist and associate professor at University College London. And my main field of interest is prostate MRI, especially during active surveillance. Yes, basically in my short presentation, I showed that there are three main characteristics of MRI lesions during active surveillance. The first one is lesion visibility. And then the other characteristic is radiomic features that are associated with imaging. And the final one is radiogenomics, basically merging data from imaging with genomic data. And in my presentation, I also showed that the monitoring of lesions during active surveillance can be done using specific recommendations, like the precise recommendations, or also other institution-specific criteria. And I also stress the importance of a good quality MRI during active surveillance in order to have a valid reporting. Okay, that's a very interesting question. So I think the first thing we have to say is that there are different protocols of active surveillance all around the world. And there is also an absence of a validated definition specifically for targeted biopsies during active surveillance. So we have definitions based on systematic biopsies. We know that the standard trust biopsy should be done according to the guidelines for active surveillance, but we have also seen that, for example, the results from the prior study in the US community, usually neither men nor physicians stick to these definitions, and the compliance with protocol-based biopsies is lower because patients consider prostate biopsy the least pleasant aspect of active surveillance. And this is the reason why I think that bar for active surveillance for inclusion or exclusion to active surveillance is lesion 4+3. And the reason of that is that, for example, in our UK cohort, we have both patients with lesion 3+3 and 3+4 prostate cancer in our active surveillance cohort. And also another very important thing is the concept of visibility versus non-visibility of prostate cancer. And I think we should keep in mind that the presence or not of a visible lesion is a very important aspect during active surveillance, because if you have a visible lesion, lesion 3+4, this is going to be more aggressive than non-visible lesion 3+4. And also we have to take into account other aspects, for example, patient-related aspects, the patient wishes, and also the age of the patient, for example. So I think this is an evolving field, and one of the most important things is that each center should know the results from their cohort, and also should have a good quality MRI, a good reporting of the scans during active surveillance. Yeah, I think there are two aspects here that should be taken into account. So the first one is the radiological expertise during active surveillance, and the other one is image quality. And these are linked to the centralization. The first point, the radiological expertise, is very important because you need well-trained radiologists to report prostate MRI, especially during active surveillance, because they have to assess the radiological change over time. And in terms of image quality, it's very important to have images of good diagnostic quality. Otherwise, the radiologist will not be able to assess radiological change. So in terms of centralization, my point of view is that centralization could be of help at the beginning, especially when you have less experienced readers. But then it's also important to disseminate the precise recommendations and the use of MRI direct surveillance internationally and in different academic settings and also non-academic settings. So centralization could be very useful at the beginning, but then we have to move to the next level, which is using MRI direct surveillance and the precise recommendations across the world. Okay, this is an interesting question. Thank you. Basically, I think that PSA density plays a very important role during active surveillance. As far as, for example, our experience is concerned at UCLH, we saw that the precise score correlates with PSA density. So we set a threshold of 0.15, and we saw that if you have radiological progression, so precise 4 or 5, it is also associated with a higher PSA density. So I think that PSA density should be actively used in the decision making for patients on active surveillance, and also, but there are also other parameters that should be taken into account. For example, the familial history or patient wishes as well, in order to have a biopsy or not. But I definitely think that PSA density is an important aspect during active surveillance.